featuring head-to-head evidence in terzepatide. May I invite our chairpersons, Dr.Ajith Kumar S., Chief Consultant, Department of Hyperbaric Medicine and Diabetic Food Care, SP Hospital, Trivandrum, and Dr.Lotika Purohit, Diabetologist and Director of Diabetes Care Center, Mumbai.
Morning. I think we'll start the next session. We have 3 talks. We have 3 excellent speakers. I think my co-chairs will join me soon. I think we all know that obesity is now become an epidemic. So we'll go into a new molecule which is available in the market and which gives a lot of hope for our patients. So first talk is why is obesity a chronic disease? The speaker is Dr. Nanditha Arun. She is a consultant diabetologist and a director of A. Ramachandra Diabetes Hospital, Chennai, founder director of India Diabetes Research Foundation. She is a fellow of Royal College of Glasgow, and she is a researcher in University of Cambridge, UK. And she received the Young Research Achiever Award in JPEF 6 years back, 2019, and the Outstanding Young Investigators Award in Tanger 2021. I think she'll be the right person to discuss about obesity, why it is considered as a chronic disease. Over to Dr. Nanditha.
Thank you, sir. Very good morning, everyone. And yes, it is always very special for me to come to JPEF for many reasons. One, because it's back to my home state where I belong, where my roots are. And of course, like sir was mentioning in my CV, it is very special because this is the same hall in which I received the Young Investigator Award, which is somewhere up on those walls as a picture. And Professor Georgie, who is my teacher sitting here in front of us, it is extremely special for me to actually be delivering a lecture in his presence. Thanks to the organizers, Dr. Jyoti Dev sir and Sunita ma'am, dear Gopika and everybody as well. I bring greetings from Chennai, from Dr. A. Ramachandran's Diabetes Hospitals. And today's session, the next couple of minutes, we're going to be discussing the theme of this conference here today, the pun behind the theme, where it says weight matters. And what the pun behind that is, of course, the way they have spelt it is W-A-I-T, but the way we look at it is W-E-I-G-H-T, or body weight matters. So recently, obesity, or how the term has actually now been changed, which I'll be discussing, has gained a lot of importance. And of course, we've always known the importance of being overweight and obese. But I think the reason why it has now come to the limelight and why it is being discussed even more is because now, in the recent past, we are more equipped with tools as clinicians to manage obesity effectively as well. So before I actually dive into the topic as such, this is my disclosure. This is a session which has been sponsored by Eli Lilly. So like I said, before I actually get into the topic as such, I would like to talk about the context of epidemiology. Why are we talking so much about obesity, and is it actually a problem in our part of the world? One would say that no, it's probably not, because obesity is more a problem in the West, and we are not obese. We are lean individuals, is what someone might assume or actually imagine. But the truth being told, that is not the case. In fact, recent data that we published from our center to show that there is a rise, we all know that there is a growing burden of type 2 diabetes in our part of the world, right? We as Indians are one of the highest diabetic capitals in the world. What are the reasons behind this? We've always known that as Indians, we are more prone to higher insulin resistance. We have a lower threshold for insulin resistance for type 2 diabetes, lower age of onset. Beyond all this, one of the independent risk factors for type 2 diabetes that we found was contributing to this rise in prevalence of type 2 diabetes was nothing but obesity. And more specifically, abdominal obesity or waist ratio, which is increasing. More so, not just in the urban areas as we would assume, but also in the rural areas. And again, not just among men, but even among women. And I have enough data which I could not include here due to regulations with the company, rules and regulations that they have. But what I'm showing you here is pan-Indian data in which we're looking at rates of obesity, the highest prevalence being in our own Kerala, where we are here today. Kerala, Tamil Nadu, Punjab, and Delhi are the states which have the highest prevalence, but all the other states are not far behind. So yes, there is a growing burden of obesity in our part of the world, in southern India, pan-India, which is contributing to the growing burden of cardiovascular disease. So obesity, as we know, there are many factors which contribute to it. It is a very complex disorder. It is not purely one factor which contributes. It is genetic, epigenetic, it is environmental, cultural factors, behavioral, physiological, many factors. It's a complex interplay of all this that contributes to the actual outcome of obesity. And when it comes to being overweight or becoming obese, there is again a complex balance between both the neuronal and the hormonal systems that contributes to accumulation of fat that then becomes overweight or obese. And this balance is what is key to address when we address the pathophysiology and try to treat obesity. So when it comes to the neuronal balance, you have on two ends. So there's two types of eating, isn't it? All of us this morning had our breakfast. But of course, the Kerala breakfast is so tasty. We woke up in the morning, we wanted to eat, and it is our hypothalamus that says you need energy, you need to eat, and that is what is the hypothalamic so-called homeostatic eating that you're seeing right here on the top, right? So the homeostatic eating is where we eat because we need energy, we need to survive, we need nutrients. That is called the homeostatic eating. That is where we are satisfied. Beyond that, how many of us this morning saw the puttu or the appam or the, yes, how many of us ate beyond that just for pleasure, just for the taste? And that is what is called the hedonic eating, right? And this is something that can, the regulation between the step beyond or the stage beyond which we eat as a necessity, beyond which we eat just for pleasure, is regulated by the prefrontal cortex, right? So this is a delicate balance that is maintained in the neurological system. Beyond that, of course, there's a strong interplay of also the hormones, which are basically the hunger hormones, which is ghrelin, which is responsible for our increase in appetite. And this is balanced by the hormones that promote satiety, namely GLP-1, GIP, the incretin hormones, insulin, and then of course the main hormone would be leptin. So all this together is what regulates our energy intake, right? When there is an imbalance between that energy intake and energy expenditure is when there is accumulation of energy which is then converted to fat and leads to overweight or obesity. And when there is, so what is the problem? When there is obesity. So what if someone is obese? So what if there is excess fat? We all know that it translates to cardiovascular risk, and how that is because there is what is the key is adipocyte or fat cell dysfunction. When there is accumulation of fat or too much of fat in the body, there is dysfunction of the adipocytes, accumulation of macrophages, and as a result of ectopic fat, which is accumulated in different parts of the body, visceral fat, all this together becomes unhealthy fat. And this in turn causes inflammation, increases our risk of cardiovascular disease. So as I mentioned earlier, we have now started addressing this and looking at it, viewing it from a little different angle, right? As clinicians, we thought of obesity as just one of the risk factors, but that is no longer the case. The guidelines and many of the societies have now termed or now accepted or now started to view obesity as a disease. It is no longer a risk factor. So the Endocrine Society of India, the American Endocrine Society, the American Society of Bariatric Surgery, all the society, many of the guidelines put together have now identified that being obese or obesity is now a disease and no longer a risk factor, and the term has also been modified to some extent, because being called obese can sometimes, sort of make the patient feel, it is a stigma, right? Socially it can become a stigma. No one wants to be called obese. It's okay to be called a diabetic maybe, it's okay to be called a heart patient, or even okay to be called a kidney, although all those conditions are probably even more serious and debilitating. The moment we say, oh, you're obese, the patient is withdrawn, isn't it? It's not a nice thing to say to someone. So the term itself has been modified as adiposity-based chronic disease, right? And what that means is that we are addressing the pathophysiology behind it more than just the actual outcome, but addressing the risk factors that contribute to the entity of adiposity-based chronic disease. So the guidelines, of course, do give us certain criteria to identify obesity, and the guidelines are, of course, you have BMI, more than 23 would be, this is our Asian guidelines, more than 23 is overweight, more than 25 would be obese. Most important is the waist circumference or the waist hip ratio, and as I mentioned earlier, the waist circumference and the waist hip ratio would be the most relevant parameter, especially in our part of the world, because we are the so-called thin fat Indians, where by BMI, by definition of BMI, many of us may not be obese. However, the waist circumference or the waist hip ratio is what is contributing to that higher cardiovascular risk. So waist circumference would be a more specific marker of underlying obesity. The ESI guidelines has also given what is called, there is what is called the Edmonton obesity staging, in which there are various stages of obesity. I'm not going to go through, it's a busy slide, but what I'd like to bring to our attention is that without risk factors or subclinical obesity with just risk factors, at every stage what is common to address is that lifestyle modification is the first step. Physical activity, diet is the first step, beyond which, when there is established chronic disease with obesity and limitations to daily activity or lifestyle, is where, that is beyond stage 2, is where it is warranted to initiate medication or supportive therapy beyond lifestyle modification. And then at the last stage, you can also include bariatric surgery. I'm going to quickly run through these. More importantly, of course, before I move on, is that many of the guidelines do recommend, whatever be our approach, whether it is, of course, lifestyle modification goes without saying, but even the lifestyle modification or the medication or whatever we advise our patients to address obesity should be individualized, right? So what that means is that when we talk about lifestyle modification, I'm going to move on to this slide. So when we advise lifestyle modification, if we have a Mrs. X sitting in front of us who is overweight or who is obese and she has severe osteoarthritis, and we tell her from tomorrow start running, not practical, right? Or if we have a Mrs. So-and-so and we tell her, even if she's young without osteoarthritis, and we tell her from tomorrow start going to the gym, she's not going to do it. So we need to be individualizing our advice to be practical, to be befitting for the patient, considering their comorbidities and cultural factors as well. So when it comes to management, as I mentioned earlier, when we divide it according to BMI, of course, the main 3 cornerstones of therapy would be lifestyle modification, and that, of course, at every stage. Beyond that, and this would, of course, be even for a BMI of less than 25. So lifestyle modification goes without saying. Pharmacotherapy can be included even beyond a BMI of around 27, and usually surgery, bariatric surgery is recommended at a BMI of 30 and above. So when it comes to lifestyle modification, as I mentioned earlier, it would be diet and physical activity. When it comes to diet, I always tell patients there is no such thing as a diabetic diet or no such thing as a magic diet. It's again what suits you. And the best way, I think, to tell patients is, if there is whatever diet, there are so many fad diets, like there is the keto diet, or there's the intermittent fasting, or there's so many fancy diets that you can adapt. But whatever being the diet, whichever you think works for you, if you see yourself being able to carry it forward for a period of at least 6 months or beyond that, even up to 1 year, then yes, go for it. But if you think you're just going to be able to do it for a couple of months and it's not going to be practically possible to sustain beyond that, then do not do it, because it's not worth it, right? So, but no doctor, I have a wedding and before that I want to lose weight. That's a discussion for another day, I think. So the diet, of course, is key, beyond which physical activity, of course, here we are having the reference of DPP, but what in our Indian counterpart, which is the Indian Diabetes Prevention Program that was conducted by my father, we found that a mere 30-minute of brisk walking 5 days a week was efficient enough to result in a 28% reduction in the incidence of type 2 diabetes. So that is, and what we're looking at over here is 58% reduction with 7% of weight loss. But in our Indian program, we found that just 30 minutes of physical activity or brisk walking 5 days a week, even without weight loss, was efficient in reducing the risk of type 2 diabetes by 30%. But one of the sort of hitches or one of the drawbacks that happens with any weight loss is that, and especially with lifestyle modification, is that when that initial weight loss happens and if there is a lack, so this is a study in which that initial weight loss has happened at 10 weeks, but then there is that regain that happens post trial or post follow-up. That regain happens because of a strong interplay between many. So what happens is when there is intense physical activity and weight loss, when there is a sort of a lull in that, or when they stop that, or when after the weight loss, what happens is that there is an increase in the ghrelin and a drop in leptin, those hormones that I was talking about earlier. That interplay starts to, there is a mismatch or an imbalance which then contributes to a rise in body weight. So when it comes to pharmacotherapy, this is what we have today approved for weight loss. We have, the first one is tirzepatide, which is a dual GLP-1 and GIP agonist. Starting dose of 2.5, we start with 2, it is an injectable once a week. The trade name is, tirzepatide is Mounjaro. What is wrong with me? Mounjaro. And injectable semaglutide is Wegovy. Mounjaro or tirzepatide is given as, started as 2.5 mg once a week, and after a month then stepped up to 5 mg. Of course, for weight loss, we can go up to 10 to 15 mg, but in India we have only the 2.5 and the 5 mg strengths. It comes as a vial taken as a subcutaneous with an injection. Injectable semaglutide, the brand name is Wegovy, and the starting dose, which is just launched in India a couple of weeks ago, just 2 weeks ago, we've all been using it for quite some time now, and the dose is starting from 0.25 or 0.5 and then stepped up on a monthly basis, because one pen has 4 doses. I think we can discuss that in the next couple of talks. The last would be Orlistat, which is an oral formulation, and we all know that it is taken with the meal. It basically promotes steatorrhea, and it causes reversible inhibition of the gastrointestinal lipases. Last but not the least, of course, we also have bariatric surgery that can address obesity. We cannot dismiss this, in spite of the fact that all of us, majority of us sitting here today are physicians, and we cannot dismiss the role of bariatric surgery. There are many people who have benefited from it. There have been instances where there's been reversal of type 2 diabetes. Of course, it comes with its risk involved, because at the end of the day, it is an invasive procedure. So we have, I think it is up to us as clinicians to know when and where to advise it, and to weigh the risk versus benefit ratio to decide if the patient is worth going in for bariatric surgery. So in summary, I'd like to conclude by sort of reiterating the fact that in our part of the world, obesity is a burden. There are growing rates of obesity, especially diabetes burden, cardiovascular disease, and we do need to wake up to the fact that people need to become more aware of this. Of course, lifestyle modification is the best way forward. And one point I'd like to mention before I conclude is that whenever, I did mention that we need to individualize our advice to patients, but one more point I'd like to include is that when we tell our patients or when we discuss the options of pharmacotherapy, when we discuss a Monjaro or when we discuss a Wegovy, whatever medication we discuss, we need to make it clear to the patient that this is not a shortcut. This is not a shortcut or a replacement to lifestyle modification. So coming back to that question where I said earlier, oh doctor, I need to lose so much weight before my brother's wedding next month. That is not what we are looking at. We are not looking at cosmetic quick fixes here. We are talking about serious burden of cardiovascular disease that is contributing to debilitating chronic disease. So correcting obesity at the roots, at the pathophysiological level would be including medication, yes, but on top of lifestyle modification, and the power and importance of lifestyle modification can never be underestimated. Thank you.
Thank you, Dr. Nanditha. She had beautifully narrated the neurohormonal modulation and relationship of food intake in obesity. I think we'll have the discussion at the end of the session. Please be seated. Thank you.